So, good day, I'm Maria Cristina Gabriel, and I will be demonstrating the emergency management for shoulder dystocia. First, we will be assessing the woman to be transferred to the nearest consultant unit or hospital for delivery. And we will also assess the client's capability to follow instructions.
Set up unique systems for calling for help in obstetric emergencies to assure that appropriate equipment and personnel are available consistent with local circumstances. Establish and practice a management protocol that includes all available healthcare providers. Post the protocol in the labor area so it is available to refer to during an emergency.
First, I will gather all the items needed for the procedure for easy accessibility.
For easy accessibility for the inspection of the external genitalia, vagina, and cervix.
So, good morning, Mom. I'm Christina, and I will be your nurse for today. So, may I know your name? Okay, Miss Diaz. So, I'll be doing an internal examination for you by inserting my gloved hands to assess the progress of your labor. Is that okay? Okay, thank you, Mom, for the cooperation.
To obtain clients' cooperation and work simultaneously.
So, Mom, you will be positioned on the examination table to assess the progress of your labor. So, there are 3 positions that are employed in internal examination. So, first is the dorsal recumbent, the Sims position, and the knee chest position.
The aforementioned positions are made best so as to expose the gynecologic area to be examined. Position depends on client's capability and examiner's preferred position.
I will put the drape on you for privacy, and I will expose only the part that I only need to assess. So I'll put the drape now, Mom.
The rationale for this is to always respect the client's modesty and to provide privacy.
For the next procedures, I will do hand washing and put on examination gloves to assess the client's progress of labor.
The rationale for this is to protect the healthcare provider from contracting gynecological diseases caused by highly infective organisms. I will notify other healthcare providers to assist or back me up during the emergency delivery and neonatal resuscitation. The rationale for this is when shoulder dystocia is suspected, the nurse can be prepared to assist staying calm and calling for added assistance with healthcare providers.
So now we'll be performing the Mcrobert maneuver, which will be assisting or positioning the client into lithotomy position in the bed. So the Mcrobert maneuver helps in straightening the sacrum and decreasing the angle of the inclined symphysis pubis, and also dislodges the impacted shoulder. So most cases of shoulder dystocia is often resolved by the maneuver alone. For the next procedure is I will instruct the mother to grasp her posterior thigh and flex them against her abdomen. So in doing the emergency management for shoulder dystocia is we need to make sure that the bed of the client is in flat, and we need to move the pillow away and make sure that the opening of the client is at the bottom of the bed. Another maneuver is done called Mazzanti Manuever, which if the Mcrobert maneuver is unsuccessful. So Mazzanti Manuever is done by applying pressure on the suprapubic region and also done with another health practitioner.
In Mazzanti Manuever, I will apply suprapubic pressure downward with palm or fist 30 seconds of continuous pressure. Apply a steady pressure first, and if unsuccessful, apply a rocking pressure. While applying pressure, another healthcare practitioner will assist the baby to deliver. Fundal pressure alone is to be avoided because of the potential neurological complications. Instead, a suprapubic pressure downward is used for 30 seconds of continuous pressure.
So another type of maneuver is called the Rubin's maneuver. So I will insert my two fingers in the posterior aspect of the armpit of the fetus, and I will rotate the shoulder towards the fetal chest. So I will insert my two fingers, then I will apply pressure and rotate the shoulder, and I will do some tractions. If the maneuver is still unsuccessful, just hold the pressure, the posterior aspect, then add another two fingers towards in the anterior. Then this is called the Woodscrew Manuever. Then do this.
Rubin's maneuver attempt to position the shoulders to utilize the smallest possible diameter of the fetus through the largest diameter of the woman. Woodscrew maneuver allows easy delivery of the shoulder once past the symphysis pubis.
Another maneuver is the manual removal of the posterior arm. So it is done by applying pressure intravaginally at the antecubital fossa, which causes the fetal arm to flex. And I will grasp and sweep across the chest and towards the opposite side of the fetal face. So I will insert my hand here, applying pressure, then flexing the arm. So this is the manual removal of the arm.
This may lead to humeral fracture if it is not done properly, which does not cause permanent neurological damage. Episiotomy. This procedure should be done by the obstetrician. Nurses cannot perform this procedure. It may be delayed until after pressure and Mcroberts. Its effect is increases room to work for rotational maneuvers.
Another maneuver is called the gasking maneuver, which is the roll over to all fours position. In this maneuver, we'll be assisting the client to roll onto hands and knees, and I will apply the downward traction to deliver the posterior shoulder, which can be repeated until the shoulder of the fetus is delivered.
This maneuver appears to increase the effective pelvic dimensions, allowing the fetal position to shift. This may impact the shoulders. It allows an easier access to the posterior shoulder for rotational maneuvers or removal of the posterior arm. Prior experience with the delivery in this position is an asset.
So 5:46 a.m. baby girl. So the baby is delivered, so we will call out the time of birth and gender of the baby. If the baby is crying, I will proceed to the EINC. If it is not, we'll cut the cord and resuscitate the baby. But our baby is crying and we will proceed to EINC.
The rationale for calling out the time of birth and gender of the baby is to safeguard mother and baby against infection, and also to facilitate spontaneous birthing of the baby.
After the baby is delivered, I will assess the motor reflex or the starter reflex of the infant and check for fractured clavicle or humerus for possible injury.
A complete symmetric motor response usually indicates no brachial plexus injury, which is the most common series resulting in injury. If an injury occurred, be prepared to discuss the possible outcomes with the parents after the pediatrician has spoken with them. 80% of these injuries resolve and cause no permanent damage with appropriate treatment.
After the placenta is delivered, I will assess for its cotyledon if it is complete. Then after, I will assess the perineum and the vagina of the client for lacerations.
The rationale for this is that this is the greatest risk to the mother from a shoulder dystocia. The hemorrhage is usually related to uterine atony or vaginal or cervical lacerations.
Next procedure is I will remove my gloves after I clean all the instruments, and I will wash after. is documentation. So we will all document the procedures and record it. So in the documentation, there is the procedure done, the vital signs of the client and the fetus, the medication needed,